Good morning. Good morning to everybody, and thanks for coming to the first Italian conference in association with SOHO, Society of Hematology and Oncology, and together with the faculty of MD Anderson Cancer Center. It is a great pleasure for me, for Claudio Cerchioni, and for the faculty to get your presence and your contribution during these 2 days in which we will try to put together the novelty and the new approaches in hematological malignancies. Just a brief presentation. What is SOHO Italy, which is the first Italian SOHO conference, aims to consolidate partnership between the Italian hematology and SOHO, bringing together leading SOHO experts and top Italian researchers in order to compare the state of art of the management of hematological malignancies in different countries. It is a new scientific international society which aims to integrate the clinical scientific activities of different countries in order to improve the clinical therapeutic approach in patients affected by hematological malignancy. We get a dream, and our dream is that patients will not need to travel anymore to receive the best and innovative treatment. But in particular, we have the aim to share the knowledge and the capacity to treat the patients worldwide. It's a new society represented by the faculty of this first annual meeting. We tried to get hospitality for young researchers in SOHO spirit. Young Italian hematological researchers are being invited and are being our guests. Moreover, the event is free, no registration cost, no cost for the young people attending to the meeting. And for people who are not in Rome, we are performing a live streaming of the conference, which can be followed by Facebook, SOHO Italy. I would like to introduce Claudio Cerchioni, who gave a great contribution of this meeting, and who will present an additional the day and the program that we have set up. Thanks.
Thank you. Thank you for your presence. We are honored to. Thank you. So the faculty is composed by me and Professor Martinelli and all the colleagues from MD Anderson. So Professor Cantargian, Professor Daver, Cartone Di Nardo, Alessandra Ferraioli, Nathan Fowler, Guillermo Garcia Manero, Eli Jabbour, Hans Lee, Tapan Kadia, Marina Konopleva, and Farah Dravandi. This SOHO Italy has been performed together in a partnership with Istituto Scientifico Romagnolo per lo studio e la cura dei tumori, our institution, of which Professor Martinelli is the scientific director, which was a comprehensive cancer network established in 2007 in Romagna, which is a northeastern area of Italy, located not far from Bologna or Venice, with over than 1 million of inhabitants. It provides in Italy the state-of-the-art in diagnosis, treatment in a very wide range of cancer fields. It is in line with the healthcare system, offering precision medicine, next-generation sequencing, and all the most innovative techniques for diagnosis and for the best treatment for patients. It's a public health authorities which coordinate the activities of IRST. Is a multi-speciality center in which there are solid tumors divisions, together with an oncohematology division in which we are integrated with the last generation treatments and organize oncology research and clinical trials inside to the Romagna and to the region. Treatment with emerging and innovative targets treatment, and moreover we have a phase 1 units in which we give the possibility to people also to have first-in-human treatments. This is the program of the event in which we divided the sessions in considering the most important diseases in hematology, and in particular we have some sessions about acute myeloid leukemia, in which we define the state of the art of this disease, and then we will focus on newest approach and the newest technique about this disease. Then we will have a myelodysplastic syndromes and rare disease session, chronic myeloid leukemia and myeloproliferative neoplasms, the state of the art of lymphomas, and then the near future with the new approaches to lymphoma, non-Hodgkin and Hodgkin patients. And then we will have a nice session about the new frontiers in health management, in which our colleagues from IRST will define how is organized our institute and how we will perform to give the best options to patients. Then we will have the state of the art in acute lymphoblastic leukemia, with the same sessions like in myeloid, so the state of the art and the newer approach, multiple myeloma and monoclonal gammopathies, with the near future, and chronic lymphocyte leukemia. We will give also our state of the art in CAR-T in Italy and in MD Anderson, which is the novel therapy about which many of us are curious. We are starting to approach with the CAR-T. And then we will have tomorrow morning the possibility to share knowledge with the colleagues from Houston, with the breakfast session, meet the expert session, in which they will be available for a round table in which we can speak with them in a friendly way, in an informal way during our breakfast of tomorrow. As Professor Martinelli was saying, we will give the possibility to follow us through social network on SOHO Italy page on Facebook, and we have social network pages in order to integrate young hematologists in our project. So, welcome here, and finally we can start this first SOHO Italy annual conference. Thank you.
First of all, I would like to introduce Professor Kantarjan and representative of the entire team of MD Anderson Cancer Center, which give us the welcome of the SOHO. Thanks.
Thank you very much. I hope this meeting is the first of many collaborations between MD Anderson and the Italian researchers who are interested in hematologic malignancies. I'm going to update you on what we do in acute myeloid leukemia at MD Anderson, and it will seem to you very, very different from what 90% of the AML experts are doing in the United States and in the world. But I believe that perhaps this is the way of future therapy in AML. So let's start with the genomic profile. What it taught us is that most patients with AML have a lot of mutations. And there are mutations which are common, which are prognostic and predictive in the setting of particular treatments, but also they are targetable. And now we are learning that some of the worst AMLs, like the FLT3-ITD, actually are doing much better than before, similar to what APL and Philadelphia-positive ALL are doing with the new therapies. So how do we exploit these mutations? In FLT3-ITD AML, we're always adding a FLT3 inhibitor, and for the younger people, we're not using 3+7. We're using either FAI or cladribine, idarubicin, high-dose Ara-C. We're adding venetoclax, and then we add a FLT3 inhibitor. We're discussing whether these people need transplant, and after transplant, we are implementing maintenance therapy in many of these patients with FLT3 inhibitors and others. Of the FLT3 inhibitors, there are first and second and third generations. If you look at single agent activity, I think gilteritinib is much more powerful than midostaurin and sorafenib, which have minimal single agent activity. So we are favoring gilteritinib in all our frontline and salvage studies when possible. Among the 20% of patients who have IDH1/2 mutations, we add an IDH inhibitor, either inacidinib for IDH2 mutations or ivosidenib for IDH1 mutations. One of the questions is, what do you do if a patient is FLT3 positive and IDH positive? we favor adding the FLT3 inhibitor because that's what determines the worst outcome. Among patients with diploid karyotype and NPM1 mutation, even if they are older, we push a lot for high-dose RC because they can be sensitive to that. If we have a patient with P53 mutation, particularly in the setting of complex karyotype, even if they are young, we shift away from the intensive chemotherapy and do either decitabine 10 days venetoclax or cladribine low-dose RC venetoclax. And these are patients that we refer to transplantation immediately. So for about 40 years, we had very little FDA approvals in acute myeloid leukemia, and then suddenly we had 8 to 9 drugs. So midostaurin is approved for frontline therapy of AML with chemotherapy, with intensive chemotherapy 3+7 in FLT3 positive AML. Gilteritinib received an approval as a single agent for refractory relapse AML, but we do not use it in that fashion. These are very expensive drugs. The FDA approval helped get the drug in our hands, but I think with all these targeted therapy, we have to use them in combination with chemotherapy and in combination with each other. Enacidinib and ivosidenib are the IDH inhibitors. Gemstuzumab came back, and venetoclax is probably a key stone in the management of AML today and in the future. So let's start with one of the rare AMLs, acute promyelocytic leukemia. This is the prime example of a tumor that can be treated without any chemotherapy, the same way as in chronic myeloid leukemia and more recently chronic lymphocytic leukemia with ibrutinib and venetoclax. So in 2000, we designed the atra-arsenic trioxide regimen with or without Mylotarg. This was taken up by the Italian and German groups, Francisco Lococo. This is not working anymore. Where do I point it to? Can you move the slides for me, please? So there was a randomized study by the Italian and German groups, and they found that actually the atra-arsenic trioxide is superior to idarubicin and atra, which is shown on the slide, and this is the long-term follow-up that shows that the non-chemotherapy regimen is superior to the ida-atra, and now this has become a standard of care. Now, the next uncommon leukemia are the core binding factor leukemia, inversion 16 or translocation 821. Here, we did not make any new discoveries, but like in pediatric ALL, we took the old drugs and combined them in a better fashion. And here, the key is the use of Mylotarg. You must use Mylotarg in the setting of core binding factor leukemia because that can increase the cure rate from 50 to about 80%. And this is shown on this slide by the MRC group, where the patients who were able to tolerate 2 cycles of FLAG-IDA with Mylotarg followed by 2 cycles of high-dose RC had a cure rate close to over 80%. The yellow curve are the patients with diploid karyotype who could tolerate this treatment. So it shows you that in contrast to the 3+7 that produces a cure rate of 35–40% at best, if we learn how to use the newer regimens that incorporate adenosine nucleoside analogs such as fludarabine, cladribine, and that use high-dose RC for induction and consolidation, you could get better results. 90% of the AML experts still believe that 3+7 is the best standard of care. I show it on this slide. So cytarabine and daunorubicin followed by 4 cycles of high-dose RC and or allogeneic transplantation. And if you do these studies, this is how it is usually tailored. You get the patients in a complete remission, then you decide if they are a low risk for transplant mortality, high risk for relapse, you take them to a transplantation. Otherwise, you do the 4 cycles of high-dose RC. I think this paradigm is going to change very quickly. The 3+7, in my opinion, should be replaced by FAI or cladribine, idarubicin, RC. We should add targeted therapy to the induction with venetoclax, FLT3 inhibitors, IDH inhibitors, and then decide on the transplant with potentially post-transplant maintenance. If not, complete the consolidations and then do maintenance therapy with oral azacitidine with or without venetoclax. So we're starting to have a lot of new concepts, and the question is how quickly can we incorporate them into the optimal therapies. If you're still a believer in 3+7, this is what you get in the younger patients on the left side of the curve, a potential cure rate at best of 35 to 40%. On the right side, if you think you can deliver 3+7 to people over the age of 60, the median survival is 9 months, and the potential cure rate is 10%. So we need to do better. We developed the FLAG-IDA at MD Anderson. It was taken by the MRC trial. So essentially, it adds fludarabine, or more recently at our institution, cladribine. We use high-dose Ara-C idarubicin, and then we consolidate with the same. I showed you already that the randomized study by the MRC showed that if you can deliver FLAG-IDA versus 3+7, there is a surprising improvement in the 5-year survival of about 20%. So this is something we should learn how to give to our patients in order to improve their survival. This is not only MD Anderson and the MRC. There's also an Italian study that was published a year ago in 130 patients under the age of 65, FAI with Mylotarg, CR rate 82%, 5-year survival 50%. So this is already ongoing in different centers. Now, I mentioned 2 new things. One is the maintenance. So the old dogma is maintenance therapy does not work in AML. There is already a randomized study with subcutaneous azacitidine maintenance for 12 months following achievement of a CR versus observation. The left side shows a significant improvement in the disease-free survival with azacitidine. So you can imagine if it was continued maybe for 2 or 3 years with the addition of venetoclax, whether we could get a much better outcome. On the right side is the survival censoring for transplant, demonstrating again the benefit of azacitidine maintenance. The second point is targeted therapy maintenance. So this is a study post-transplantation in FLT3 ITD patients where the patients who were randomized to sorafenib did significantly better than the patients observed for post-transplant. So we should not think of transplant as a one-time procedure anymore. Transplant is part of a total approach to the patients where we have to incorporate post-transplant maintenance either with targeted therapies like FLT3 inhibitors, IDH1/2 inhibitors, or with azacitidine, venetoclax, or maybe many of these combinations. This is an important breakthrough. So the old dogma in AML is that maintenance therapy doesn't work. There is a study with oral azacitidine, which actually is absorbed at only 10 to 30% of the subcutaneous azacitidine. But it's given for 2 weeks every month. And now, 2 weeks ago, there was an uncovering of this data. So patients in remission who were randomized to either oral azacitidine versus placebo, and there was a statistically significant survival benefit favoring oral azacitidine. This is a major breakthrough from the old dogma, and I think we're needing to learn very quickly how to incorporate azacitidine into maintenance therapy of AML, and perhaps look at the oral azacitidine for 2 weeks versus subcutaneous azacitidine even in myelodysplastic syndrome to improve the outcome of these patients. These are the things that definitely work: FLT3 inhibitors, IDH1/2 inhibitors, venetoclax, and oral azacitidine maintenance. I show here the Mylotarg to emphasize that in the core binding factor leukemias, if you add Mylotarg to chemotherapy, you can potentially improve the cure rate from 55 to over 75%. So gemtuzumab ozogamicin is a must in every patient with core binding factor leukemia. The FLT3 inhibitors will be discussed in details later. As I mentioned, we favor gilteritinib now because The toxicity is manageable. As a single agent, it's the most powerful one. And there is single data that led to the approval. But here's how we're using it today, not with 3+7, but with FAI and cladribine, idarubicin, Ara-C. But there's already published data with gilteritinib 3+7 demonstrating a universal CR rate in these patients. IDH mutations occur in 20% of the patients, and the approvals are for single agents in the setting of salvage therapy. But we know already that in combination, both frontline and in salvage with intensive chemotherapy and low-intensity chemotherapy, we get better results. This is a frontline single-arm trial of 3+7 with either of the IDH inhibitors, very high CR rates. But look now at the estimated survival. On the left side are the IDH1 mutated. We're not talking about a survival of 30 or even 50%. You could potentially cure most of these patients. On the right side are the IDH2 mutated patients. Now, if you use it with low-intensity therapy, in the middle I show single-agent ivosidenib frontline, CR rate 30%, median survival 12 months. On the right side are the ivosidenib azacitidine, CR rate doubles, 61%, and the 12-month survival is 82%. So we should not use these FDA-approved drugs as single agents. We should use them in combination and preferably in the frontline setting. Venetoclax will be discussed later. Suffice it to say that combining venetoclax with azacitidine in older patients with AML gives us now a marrow CR rate of 70+%. We'll show from MD Anderson data of a marrow CR rate of 80 to 90%. And the median survival is not anymore 7 to 9 months. It's close to 1.5 years. So on the left side is the survival with epigenetic therapy and venetoclax versus on the left side single agent azacitidine. So we're hoping that the randomized study, if it doesn't cause too much toxicity in the venetoclax arm, will lead to a final approval of venetoclax in AML therapy. On this slide, I show 3 leads, and I'm not sure that they are going to be true or not because they come from very single-arm trials, very small single-arm trials. On the left side is the APR-246, which is under development for P53 mutated MDS and AML. In the middle is an unconjugated CD70 antibody used with azacitidine in AML. And on the right side is the macrophage activator anti-CD47 antibody. We're hoping that maybe one or more of these will be positive, but I have my doubts about them because they come from very small single studies. Older AML will be discussed with Dr. Kadia. We have developed low-intensity therapies with venetoclax with the addition of targeted therapies, so this will be discussed later. So finally, these are the things that work: FLT3 inhibitors, IDH inhibitors, venetoclax, oral azacitidine maintenance. We're exploring more antibodies and CAR T-cell therapies, but there's nothing earth-shaking as in other tumors. And at the bottom are the 3 hopeful things: the CD70 antibody, CD47 antibody, and the APR-246. Thank you for your attention. Shall I introduce the next speaker? Okay. Questions?
In your great experience about AML, which patients do you think will be the best to select for AZA maintenance, which is really a breakthrough because a maintenance with a statistically significance in overall survival is really a great news for us?
I think it's going to be all patients, young and old. Once you finish your standard care, then we should develop something with oral AZA maintenance. I prefer it to be with venetoclax too. And if they have a FLT3 mutation, you add a FLT3 inhibitor. If they have IDH mutations, you add an IDH inhibitor. That's the future, and the faster we get to that, the better it is for our research and our patients. So at MD Anderson, we're going to start designing studies with oral. We have already a study with subcutaneous AZA venetoclax. As soon as we can, we may replace the subcutaneous AZA with oral azacitidine together with venetoclax.
Perfect. Thanks. Questions? Yeah.
Thank you for this overview, and I do agree on the fact that 3+7 is not anymore the standard of care in AML. But the question is, the problem, I mean, is that all the ongoing and the recently published trial in AML testing new drugs are using 3+7 as the control arm. So how is our ability to evaluate the real benefit of the new molecule in this setting?
So that's the problem. I think 90% of the AML experts believe in 3+7, and they push for all the randomized studies to be with 3+7 as a standard arm. The Germans are doing this, the Americans are doing this, and that's frustrating to us because then we say we cannot participate in those randomized trials. And I think it's an easy way for people because in the United States, 3+7 can be delivered in the community setting, and they say we can do as well as elsewhere. But there's now a study looking at 70,000 patients with AML, and it shows that the early mortality at 4 weeks is more than twice higher in the community centers than in academic centers, 28% versus 16%. And in academic centers, it's twice higher in the non-NCI designated centers, 24% versus 12%. At MD Anderson, the 4-week mortality is 2 to 3% in elderly with the low intensity and less than 5% in the younger. So I don't think AML or leukemias are diseases that should be treated in the community practice. They should be treated by the best leukemia experts. And that's why I think the studies that are trying to compare FAI or cladribine, idarubicin, Ara-C to 3+7 end up on the negative side because it's a community doctor. The mortality is high. They don't care. They do want 3+7 to remain a standard of care. And that's how we miss showing that the more powerful regimens are better. The MRC showed it, and then they said FLAG-IDA is too toxic. Transplant is toxic. Right? So you have to learn how to use these regimens. Thank you. So let me introduce the next speaker, Dr. Daver from MD Anderson, Novel Therapies in AML at MD Anderson.
Hello. Okay, thank you very much for having me here. I am one of the leukemia faculty here at MD Anderson. It's a pleasure to be here, and Dr. Martinelli and Sessione, thank you very much for setting this up. Very nice organization. So my task was to talk about the novel and emerging therapies in acute myeloid leukemia. So you heard an overview from Dr. Kantarjan about the established agents, the FLT3 inhibitors, venetoclax, IDH inhibitors, potentially now oral azacitidine, and there are a few novel or emerging drugs as well, especially 4 or 5 of those that we think could be interesting, and I'll focus more on those as well as novel combinations that are emerging. So as we know, there is now a tremendous amount of exciting clinical data emerging in acute myeloid leukemia. One of the major challenges with such an amount of extensive data and new drugs, 9 drugs potentially approved in the last 2 years and new data emerging, is how we optimally combine them, because as single agents, each of these drugs may give us a proportional benefit, but really to see the full impact and improve the cure rates or the 3 or 5 year survivals, I think combinations are critical. And one of the way we look at it is combining, for example, new cytotoxic or HMA agents, as was discussed, such as oral azacitidine or Vyxeos, with the emerging targeted agents, IDH, FLT3, venetoclax, and potentially adding some form of immunotherapy as a maintenance or a MRD targeting agent. So you're going to hear a lot about the venetoclax plus HMA, venetoclax low-dose cytarabine, and the data is fantastic. The most recent update, the median survival is in the range of 16 to 17 and a half months, with CR/CRI rates 3 times higher than we used to see with AZA or decitabine alone, about 70 to 75%. But at the end of the day, we're at 17 months, and the 2.5 year survival is 45%. So one of the big things we're focusing on in our group is how we can potentially improve this and overcome HMA or low-dose RRC venetoclax resistance, which in fact is becoming one of our large referral populations because people are using it in the community, and after time, the patients do relapse. So also the other thing we're seeing is in relapsed acute myeloid leukemia, where we also hoped that the efficacy that we saw in the frontline setting would be replicated. We did not see the same benefit, and there have now been 3 or 4 institutional studies from our group, Dr. DiNardo, as well as from Sloan Kettering, as well as City of Hope, and these are showing that the CR/CRI rates with HMA-VEN, different combinations, AZA or DAC, are in the range of 30 to 35%, and the median overall survival is between 6 to 8 months. So in the relapse setting, we still have a need for improving treatments. One of the approaches we tried with a 10-day decitabine, which in the frontline setting is now giving us 90% and higher CR/CRI rates, will be updated at ASH this year, but in the relapse setting, again, we're not able to get much higher than 30-35%, and the survival remains poor. So our group in the lab, Dr. Michael Andreev, Marina Konopleva, and colleagues have been working extensively on mechanisms of resistance to venetoclax. This was a paper that was published a few years ago in Cancer Cell from Dr. Andreev and Konopleva's lab, and we know that there are a number of mechanisms of resistance, but it seems the 3 or 4 most important ones seem to be upregulation of a concomitant anti-apoptotic protein, MCL1, and this is one of the escape mechanisms that the tumor is using to overcome BCL2 inhibition. The others seem to be mutationally, and there is some signals that have to be confirmed that at the diagnosis or at the relapse, there could be primary or secondary resistance to the HMA or low-dose RC-VEN or shorter duration of response or survival with FLT3 or TP53. And some of this data will be updated at ASH this year. So you see now there is development of the next generation of combination treatments. These include other MCL1 inhibitors, MDM2 inhibitors, as well as potentially combinations with FLT3 and TP53. One of the new drugs among the 4 or 5 that I will discuss that we may see some data emerging very soon is one that has actually been used quite a bit here. This is a drug, Idesanutlin, and the phase 1 was led by Dr. Martinelli. I'll show you the data on that. And we are now doing a new combination of venetoclax with Idesanutlin to overcome that resistance that I mentioned, potentially through concomitant blockade of the MCL1. This will be updated ASH this year, but we are seeing CR/CRI rates in older patients, this is for only patients above 60 with relapsed AML, of about 45 to 50%, which is encouraging, but we have to wait for the durability and the survival. And eventually, if this is encouraging, as was discussed previously by Dr. Kantarjan, the question is how we can combine this with HMA-VEN in the front line with appropriate reductions in duration and dosage, and this sort of study already is being developed. This is the phase 1b study of the Idesanutlin. This is an MDM2 inhibitor. There are 3 or 4 of them. This is the one that's most advanced in the clinical development. This was presented a few years ago at the EHA meeting. Will be published soon, as well as what I hear. And the overall full CR rates, these are not CRP, CRI, CR rates in relapsed AML in combination with intermediate dose RSC were encouraging at about 38%. So this has now led to a phase 3 randomized study called the MIRO study, which is about 90% accrued at the last update, and we hope by end of this year or early next year, we may have a early signal readout. In fact, there is an interim analysis in November, as I am aware. This is for patients who are above 60 or relapsed acute myeloid leukemia, first and second salvage population, and patients are randomized to the MDM2 inhibitor plus intermediate dose cytarabine 1 gram per meter square days 1 through 5, or placebo plus the same dose of intermediate dose cytarabine. And of course, transplant is allowed. This is powered for overall survival. Expected survival with this population is 6 to 7 months. So the target is to get to 9 or 10 months. And if it's positive, then potentially another drug that we can then develop with more novel and frontline combinations to move this bar further. What about FLT3 or FLT3 and venetoclax? Is there a role? And actually, there is a lot of biological rationale for this. This is data that we did using pre-treatment and post-treatment, meaning at the time of relapse, whole exome sequencing on people who were treated with the single agent venetoclax in relapse refractory AML, a study that was done by Dr. Konopeva from our group. And what we saw is, again, remember, this is single agent venetoclax, that people who had baseline FLT3 or PTPN11 mutations had very little reduction in blast or response at all to single agent venetoclax. And more importantly, in the bottom you see in purple that there were some people who did not have a FLT3 and started acquiring it after they were relapsing. So maybe a mechanism of primary and secondary resistance, and you see that the survival of the people with the FLT3 mutation with the single agent ven was extremely poor. So this led to the question that, like we see with IDH, like we see with others, could FLT3, PTPN11 RAS, which work in a similar transduction pathway, lead to resistance to venetoclax? Dr. Konopleva will be discussing this more in detail. There is some emerging data that Dr. Wei from Australia, who is leading the low-dose RRC venetoclax, has shown that among the intermediate cytogenetic risk population, if you look at the non-responders, which was about 20%, of those, more than half had a FLT3 ITD at baseline. So this is a hypothesis, and this will be analyzed further with the HMA and the DAC10-day combinations, and this is what our group has felt is the case in our experience, but these are small numbers because the FLT3 mutated often go on to FLT3 inhibitors like gilteritinib, quizartinib, but we will wait and see. And there is preclinical data that Marina has shown in her lab, combining both midostaurin and quizartinib, showing that there is a potent synergy because these FLT3 inhibitors also seem to inhibit MCL1. So at this year's ASH, you will see some very exciting data combining gilteritinib with venetoclax, as well as there are studies looking at quizartinib, venetoclax, and triplets of these moving forward. And we believe that this could push the FLT3 frontline older population response and survival to maybe above 22 months. And in the FLT3 talk, we will discuss some of those details with the HMA and FLT3, but I think this is a further encouraging signal. So what about other combinations with venetoclax? There's an IDH that Dr. DiNardo from our group has done, and this, again, as a doublet, has shown 80%. So remember, single agent IDH 1 and 2, 35 to 40% CR/CRi. Here we're seeing almost 80%. Again, early data, but very encouraging and well tolerated. So another important mechanism. So we discussed the MDM2 MCL1, we discussed the FLT3 resistance, and then the last drug, which Dr. Kantarjan mentioned briefly, which we're very excited about, right now more in MDS because that's where the lead study for their registration is, but hopefully soon in AML, is a drug called APR. The mechanism is not clearly understood. It seems to affect TP53 folding and in a way impact the outcome in TP53 patients. The response rate shown at ASH got everybody very, very excited. 100% responses in AML when we combined CR/CRi and true CR rates of 65 to 80%. So this has led to a phase 3 registrational study in MDS and other studies in AML, potentially in combination with HMA or HMA-VEN, and we have to wait and see because we need more numbers to make a final decision. And in the next section, I'm going to talk a little bit about the immunotherapies. I think there are other discussions on this later in the day. We are working a lot on these in AML as well as in MDS. Of course, in ALL, these are very, very established already. I think it's important when we say immunotherapy to understand the concept. So you have antibody drug conjugates, which are really a way of delivering a targeted cytotoxic payload in a more specific way to the tumor cell. And that's not the one that solid tumors usually are thinking about when they say immunotherapy. For them, the immunotherapies are more the checkpoint inhibitors, bispecifics, T-cell engagers. We, of course, use both these modalities, but they work in very different ways, and I think they will work in very different settings based on some of our experience. So you've heard about gemtuzumab. This is the only approved immunotherapy in acute myeloid leukemia. There are a number of emerging antibody drug conjugates. Two of them that we feel could be exciting in the near 1 or 2 years are a CD123 antibody drug conjugate called IMGN or Immunogen that we have been working on, which seems to have a more potent toxin and a non-bacterial toxin, which is one of the things we're looking for because we do have more difficulty and issues with the bacterial toxins. And the other is actually a drug called cusatuzumab, which is a anti-CD non-conjugated antibody, again with early data, which could be exciting. So the CD123 that we've been working with at MD Anderson, and I think is also open here in some sites in Italy and Spain and in Europe now, is showing activity, modest activity as a single agent, about 25% CR/CRI in the relapse second or third salvage. Again, I think that's a good proof of principle for safety, but eventually the question is, can we combine this? And a combination study with AZA and AZA-VEN is ongoing, and we will have to wait and see. The other conceptually very exciting idea that we borrowed from acute lymphoblastic leukemia, where our group has led the blinatumomab along with the European colleagues, is to develop a bispecific antibody. So what are we trying to do here? We're trying to harness the T-cell immune system and use the T-cells to kill the AML cells. So we target one of the AML-directed antigens, CD123, CD33, CLEC12A, TIM3, and we link it to CD3, allowing the T cells to come close and kill the AML cell. Dr. Farhad Ravandi from our group has been working on a number of these bispecifics. There's some with Amgen, XmAb, others. The one that has the most clinical data so far is a drug called flotetuzumab. This was presented at ASH a few months ago by Dr. DiPercio and Uy, and they are seeing some activity. The overall response rate is about 18 to 20% in relapsed AML. There is CRS, which is manageable according to the presenters in most cases, but does require inpatient and close monitoring. So I think these are now moving into combinations with checkpoint inhibitors, other approaches, and we have to wait and see if the responses will get better and the CRS can be managed when we combine these modalities. In the last couple of slides, one of the areas that we have been also working with, which goes along with the bispecifics, has been the immune checkpoint antibodies. This was the data we presented a few months ago and published, and it shows that the combination of HMA with the PD-1 inhibitor nivolumab appeared to be safe and effective with improvement in responses, better than what we see with single-agent AZA/DAC, and in the range we are seeing, for example, with the HMA venetoclax presented data from the different centers. I think what's emerging with immunotherapies, such as we have seen with the blinatumomab in ALL, is that you have to pick the patient correctly. So if you're looking at salvage 1 population, people who have low blast disease, where you have a mature active immune system, which actually has been published even in AML, you could harness this by bispecifics as well as immune checkpoints. And we are seeing that in our study, where in the salvage 1 people, most of these, 85% were 60 plus relapsed AML, we have median survival more than 10 months, which is quite encouraging compared to our historical experience. But in the second, third, fourth, fifth salvage, advanced salvage, when we look at the bone marrows, which was part of our correlative analysis, we see T-cell depletion, and the T-cells that are present are not functioning. So I know in Italy there are a number of investigators I have talked with who are developing preclinical and clinical studies with these combinations, and I think I would urge to use this in the earlier relapse or as a maintenance in a low burden setting or MRD rather than third or fourth salvage populations. And this is some data that we showed in our paper looking at baseline T cells and predicting response. Important thing with all the immune therapies, whether we're talking about bispecifics, immune checkpoint, CAR T cells, which I know will be discussed extensively, is that you can get many different types of itises. These are non-predictable. They do not have a consistent timeline to occur. We've seen them within days or weeks. We've seen them after months of the last treatment. And we are learning that management of these is probably crucial if these drugs are to move forward and succeed. And in the community and smaller academics where people have not used these drugs as much, I think there is a struggle. The last drug I'm going to discuss is one that kind of goes in the same immune checkpoint bispecific pathway. This is a drug, CD47 antibody, but instead of activating T cells that the solid tumors have done for many years successfully, this activates the macrophages, which based on some high impact papers published a few years ago from the Stanford group, may be a more important bone marrow infiltrating component in AML. Early data, again, 25 patients, but response rates of 70 to 80%, especially in MDS, talking about 90%. we have to wait for this to mature. Things always look good very early on. The safety to me is what's interesting. It seems to be extremely safe. They haven't seen the itises like we see with the T-cell antibodies. So we will wait and see if this matures, and of course, potentially combine it with HMA-Ven in the future, and a registration phase 3 in MDS has already begun. So overall, I think in the frontline setting, we have a new standard, the HMA-Ven. All the studies we are doing, we are reincorporating or redesigning them to use HMA-Ven as the backbone. But still, in patients with TP53, FLT3, and relapsed AML, I think there's a need for improvement. Some of the potential angles that we think could be effective are MDM2 and MCL1, or FLT3 IDH, and triplets of these have actually started for all of them, for FLT3 IDH1, IDH2. Couple of drugs that are in phase 3, MDM2, that hopefully will read out by the end of this year. And then there's an E-selectin inhibitor also that has started a phase 3 that targets tumor microenvironment. And I think immunotherapies are in the development 4 or 5 years in, and will take more time to understand and use them. But most importantly, similar to what Dr. Kantarjan said, I think we may now be looking from a telescope, but hopefully looking at 3+7 being pushed out for large majorities. And can we now develop effective triplets, maintenances, incorporate immunotherapy? Myeloma has done this and got rid of VAD, vincristine adriamycin dex, which was the answer in my boards 18 years ago, and we don't talk about it, and maybe incorporate targeted therapies and remove high-dose chemo and transplant. And with that, I will stop and take questions. Thank you very much. Dr. Martinelli.
Fantastic presentation. Of course, all of this combination has to find out finalization and to make a choice. What's the strategy for making combination? Is reducing toxicity, reducing mortality, early mortality, prolong the survival even if not completely cured? What's the strategy in your opinion in the combination in acute myeloid leukemia in the future?
Yeah, that's a great question. I think for the next 5 to 10 years, the focus is going to be improving survival. You know, even with HMA-Ven, even with FLT3s, we are better, but we're still talking 15, 18 months. So we're not, you know, at the 5-year cure rates of 70, 80%. So I think our two focuses are improving survival and reducing early mortality. I think the next steps will come, as Dr. Kantarjan and others will talk about, is how we can move to oral therapy, which will be convenient. But I think the first push is how we can really optimize survival for these populations. And I think that's where the triplets will come in. But one of the keys is, when we're talking about triplets, these are not 1+1+1. That is not possible. The cumulative toxicity is just impossible, even for some of the doublets given continuously. So I think these have to be done in trials. There is a learning curve. We are reducing durations of Ven that you will hear from Courtney and Marina. We are incorporating early marrows. We're using growth factors when needed, and we're adjusting the dose of the targeted therapy. So I think there's a package approach to this, but the key is still improving survival.
Al, congratulations for your talk. I have another question. Professor Kantarjan told us that probably the dogma of not performing a maintenance has changed. So what do you think about, you're an expert of immunotherapy, what do you think about incorporating just novel immunotherapeutic agents in maintenance? Because as you told, the problem is the overall survival. So do you see a role for maintenance for all these new drugs that you show us?
Yeah, absolutely. I think the oral AZA was not only positive as a trial, but as conceptually very important, because I think people are afraid of maintenance studies. You know, it takes a long time, 8, 10 years, millions of dollars, and then if you're negative, your drug is gone from the market. So I think hopefully this blinatumomab in ALL, oral AZA in AML, in the MRD maintenance will make the regulators also start thinking about this as an endpoint. I know they're already thinking about it. And I agree that the immune checkpoint, the bispecifics, maybe the 47, that seems a little different, would be well done in a maintenance setting and potentially improve survival. Yeah.
In AML, so there's a learning curve. You have to be very careful. If you see any any patient where you're using a checkpoint inhibitor, where the patient looks like he has fever, low blood pressure, hypotensive, sepsis-like, you could lose a lot of patients if you delay the implementation of steroids. So antibiotics and steroids. Unlike venetoclax and the targeted therapies, which seem to be safer with the checkpoint inhibitors, I think it's a more dangerous route, and it should be always done in the context of trials and maybe in single centers before you explore it in multi-institutional. Checkpoint inhibitors in leukemia are more difficult to give and more dangerous to give, and we don't know their true benefit at this stage.
Yeah, no, I think this should be done only in trials. Now, the maintenance MRD may be nice because, as we said, there are 2 trials looking at it, and it seems it may be better tolerated, but absolutely, I think this should be both bispecific checkpoints in trials. Yeah. Okay, well, thank you very much. Let me introduce Dr. Martinelli, who's coming up for the next talk. All right, thanks.
You can stay there.
Pleasure and honor to introduce Professor Martinelli in order to compare the state of the art of novel agents approach in MD Anderson Cancer Center and so USA and in Europe and in particular in Italy.
Thanks. I tried to focus the attention of some new drugs that are coming in Europe. As usual, we get more rigid and more difficulties to get approval of the drugs, probably because the European public health system has to pay and sometimes will be reluctant to introduce new drugs in a short time. Particularly my government, my country, as Spain usually do, they takes an additional 1 year to get the approval of the drug. So every time the drug is available in the United States and approved, there is about 1 year and a half to get the approval and the reimbursement in Italy. However, the marvelous situation that has been given the approval of five drugs in the short time, which has been mentioned, has been taken also by EMA approval in a very short time. And I would like also to remember that amsacrin comes back and has been recently approved for acute myeloid leukemia refractory resistance, which is an additional drug that has to take care in the future. Let me come to present 3 or 4 drugs that are probably a breakthrough in acute myeloid leukemia. The first is related to the fact that FLT3 is frequently involved in between 25 to 30% of acute myeloid leukemia, depending from newly diagnosed or relapsed population. But at the end of the day, we are currently unable to cure this disease, particularly when they relapse refractory. It's a very difficult population to be cured. And whatever is the experience we get in at least 15 years of treatment, we don't get until now great results on this tremendous acute myeloid leukemia. One of the drugs which are probably more satisfactory in the clinical development is the gilteritinib, which has been approved in a very short time from FDA and from Japan regulatory agencies, particularly because even if the overall survival data are not available, the FDA decided to approve the drug based on the response. And before getting any results, which will be published very short time, probably during the ESMO meeting by New England Journal of Medicine, without any publication, the FDA approved these drugs, which means probably particular interest for the clinician to get this drug as soon as possible. This is a small molecule that inhibits multiple receptor tyrosine kinase, including FLT3. Is very well tolerated, and I just moved to the phase 3 clinical trial. There was a very short development in phase 1, very aggressive way to develop phase 1 with big cohort in the phase 1 dose finding, getting immediately safety profiling in the majority of the single agent cohorts in relapsed refractory population. Then we move on to the clinical trial, which was a clinical trial related to enrolling 369 patients, gilteritinib 120 milligrams daily, versus whatever is the salvage chemotherapy, low dose cytarabine, azacitidine, MEC, FLAG-IDA. This is something that we make experience, one drugs alone versus whatever you want, the best in town, which Professor Cantargian has developed, for instance, in the innovative clinical trial and also in the development of Blincito, getting the single agent drugs versus whatever is the best in this moment for relapsed refractory population. And the results were quite interesting, 28.2 getting CR/CRh, 19% CR, 27 patients out of 142, 9.2 CRh, again 13 patients out of 142, median duration remission 421 days, median duration remission 122 days. So there was a clear advantage in the population treated in respect of conventional chemotherapy. Taken together, we can take CRC in 46% of our population. Mostly of these patients getting CR or CRI, some of them getting only CRP, which means that the majority of the patients getting a prolonged advantage in median duration remission and advantage in median times of first relapse. The other clinical trial, which takes a lot of time to be developed, let me say the quickness of the gilteritinib was associated with the no speed of the development of quizartinib, taking a lot of time to conduce this phase 3 randomized controlled quantum R trial. A lot of people in the room has been involved in this, which was again a very prolonged dose finding of quizartinib. At the end of the day, we decided to use 30 milligrams for 15 days, moving to 60 milligrams. But I would like to remember we started with 200 milligrams, more than 200 milligrams, then getting down, particularly because the QT prolongation was an aim in the treatment of this patient, which was compared with the salvage chemotherapy, low dose RC and MEC or FLAG-IDA. Let me say the population was a bit different. More aggressive, relapsed in 6 months, majority of the patient getting young population and getting also sometimes a more aggressive disease. So the quantum R, in my opinion, was related to a population without any MDS feature, any previously treatment with azacitidine. So the population was particularly acute myeloid leukemia with bad prognosis. And the results are quite good, but not probably as we expected to get from a single agent. Quizartinib getting 6.2 months versus 4.7 months overall survival. Now the sub-analysis make more clear that the population getting to transplantation getting very good, getting better. But however, these drugs was probably insufficiently in the results as we believe at the beginning. And the drug has been refused by FDA, approved by Japanese authorities, and now is under evaluation this day from EMA. The dossier has been presented. Let me say again, the rate of CR/CRi is quite similar to the of the gilteritinib, 48 patients getting CR/CR, getting a more patient getting PR, 69, and a few patients getting no response. So the drug works, but it works probably less than the other. So we decided, according to the Italian authorities, to try to collect what's happening in FLT3 mutated acute myeloid leukemia patient with an observational multicenter retrospective study, which has been promoted by my institution. We are planning to collect 1,800 patients in 44 centers which is ongoing from the April 2018 of the last year, and you could participate in this program. The other drugs that has been registered, and we get an additional section, is CPX351, an advanced nanoscale liposomal technology. You know that this was first dual drug advanced liposomal formulation, 5:1 synergistic molar ratio of cytarabine and daunorubicin, and this can be probably optimize the efficacy of the treatment is a sort of 3+7, but now the formulation permitted a more available drugs in the bone marrow and probably the activity at this level. It has been initially applied in a randomly allocated population with CPX versus 3+7, and majority of the patients getting this schedule, which is the first induction 100 units per square meter, day 1, 3, and 5, reinduction and consolidation versus the population which has been treated with canonical 3+7. The population was a population particularly in elderly patients with advanced and with secondary leukemia and with adverse cytogenetic, and the survival was clear important, give a clear importance, and also the plateau in this population, which is not easier to be reached, means that the drugs is active at leukemia level, and in particular leukemia stem cell level. The other drugs that has been recently approved by European Community and is approved in the United States is a new drug which is SL401, which is a truncated diphtheria toxin payload to the EL3 receptor monoclonal antibody. So the CD3 receptor, which is also called CD123, Naval presented some of the data of other drugs working at this level, is expressed in mainly hematological cancer, leukemia, lymphoblastic leukemia, some CML, MDS, Hodgkin lymphoma, particularly non-Hodgkin lymphoma, certain non-Hodgkin lymphoma, but it is also expressed in some important malignancies like BPDCN, and this was the registration. You remember that this is associated, is a leukemia associated with cutaneous, very important skin lesion, and elevated expression is in the majority of the patients very high, and the drug is very highly potent against this disease, so the drug has been registered for this disease. Of course, this need, since it's a very rare disease, necessary to be applied in a consortium for rare cancer and rare leukemia that some of our INGMEM are being trying to set up. And of course, we asked to get the drug. The proposal has been submitted several times. 2 times we started 3 years ago to ask to get an open label phase 2 basket study with using these drugs. I'm very curious to know what's the opinion of the MD Anderson Cancer Center later on these drugs they developed. So in conclusion, we can probably divide acute myeloid leukemia in some of the acute myeloid leukemia getting canonical translocation with the TKI or TF transcription factor activation, and these are probably overexpressing MCL1 and BCL2, but the chemotherapy we are using, the new drugs we are using, make this degradation of BCL2 very easier, so we get a curable disease. When we get the FLT3 internatando duplication, the MCL1 BCL2 degradation is less degradable, and we get less curable, and the recurrence of leukemia comes frequently. When you get an aneuploidy or P53 mutation, particularly if you get monosomy 5, monosomy 7, and so since the majority of the E ligases activity is related to this, located in these 2 chromosomes, MCL1 is not degradable, and so we get mostly incurable disease, and particularly leukemia recurrence. And this is particularly important because we can divide this in good, bad, and ugly. I don't know if the MD Anderson will approve this Italian film paradox. Recently, we tried to understand, analyzing more than 1,200 12,000 cancer, but particularly 700 leukemia. If there is some canonical pathway that we can, some canonical signaling that we can target better, and this was good for getting not only in solid tumor but also in leukemia, three main signaling. The first is inflammatory, NFKB signaling. The second one is related to chromosomal instability, and the third is related to defective ubiquity in proteasome system. And in other ways, we get leukemia stem cells, which is very difficult to eradicate, even if it is deeply rearranged and mutated, but there are some additional scaphoids, which means additional mutation and a genomic lesion in a microenvironment which is particularly difficult to be eradicated, and in a context of the bone marrow, which is so cloudy, difficult to be eradicated, and it could be very difficult to eradicate the disease. So the first point is probably to fix the leukemia in a point which is related to the genomic instability. Genomic instability is probably our difficulty to eradicate the leukemia, because every time we use drugs, we get some mutation. And I would like just to make a suggestion. I have no time to go in details, but using ponatinib experience in acute lymphoblastic leukemia, trying to avoid the mutational load that comes with BCR-ABL, and getting an advantage from the fact that if you treat a patient with acute lymphoblastic leukemia with ponatinib, the best drug we get, probably TK we get in acute lymphoblastic leukemia pH positive, we get avoiding mutation, avoiding karyotype and clone evolution. So just to show you that every time you get BCR-ABL, this is my canonical pathway that is activated not only in acute lymphoblastic leukemia pH positive, but probably in acute myeloid leukemia also. Getting a tyrosine kinase activation, an activation FLT3, a SRC kinase activation, which means a lot of things, CDK6, and the end of the day MCL1 and BCL2. So BCR-ABL inhibitor or other TKI inhibitor can be used, FLT3 inhibitor can be used, of course. Sometimes we can have also some SRC inhibitors, CDK inhibitors, and MCL1 inhibitors are being used, but every time we use a single agent or individual agents, we get recurrence of mutation, which conference resistance, and we can use a good drugs targeting more of these simultaneously, and we can use steroid at the beginning, so avoiding mutation. So why this ponatinib works? We searched in a gene expression profile. I don't go in details, and we find that the cytidine deaminases and the ApoBec signaling, which is the more important editing enzyme, making a lot of mutation, because the conference mutation make a C2T signature expression, and these make an extremely high mutational load. So I try to summarize in a cartoon. Every time you get a leukemia stem cell getting an oncogene, whatever is the oncogene, this is being sensed like a virus inside the cells. So every time you get an infection, you get double-strand RNA, and this opening in 3 hours DNA damaged signaling, which is related to the overexpression of P21 and downregulation of P53, and a lot of don't touch, don't take me signaling has been activated, which means also an immunological defect. So the cancer stem cells became similar to a virus, and usually the infected leukemia cells activate the canonical CDA, cytidine deaminases, ApoBec, and ApoBec B3 overexpression. So every time we get this, we get an extremely high editome, high mutational load, and this makes possible that the leukemia stem cells conference mutation for EDH1, mutation for FLT3, mutation for BCR-ABL. Using drugs like ponatinib, we remove this mechanism of editome, we remove this genomic instability, we fix the cells, we probably shut off the P21, we reactivate P53, and at the end of the day, we eradicate or permit more easily eradication of the disease. And this is related to the fact that ponatinib is not only working on toll-like receptor signaling, which means antiviral response, editoma, CD8, ApoB and R1, pro-inflammatory cytokine survival factor, survival DNA repair, apoptosis, but more importantly, at the end of the day, ponatinib is able to promote necroptosis, pyroptosis, and ferroptosis, which is the canonical virus response to apoptosis. And then I would like to remember that this has been done using a canonical registry of BCL2. I have no time to enter in detail for venetoclax, but venetoclax is a potent drugs for acute leukemia. How we can activate more activity on venetoclax, increasing ROS and reducing NAT pH. So the idea was to get an inhibition of glucose-6-phosphate dehydrogenase to increase ROS and to get more destruction of the majority. And then I would like to thank you for attention and open for your question. Thanks for attention. I probably consumed the time for the discussion, correct? Bernie, question?
I was fascinated by the ponatinib story. All the story you presented, do you think implies that the real effect is not only on the blast, on the transformed cells, but on the microenvironment? Yeah,
that's true. We get strong evidence that the entire microenvironment was totally different in the ponatinib-treated population. The microenvironment inflammatory was shut off, toll-like receptor signaling was shut off, whatever is the cells, because it's not just for the blast cells that we are curing. Immunological competence, we reduce the Treg, we increase the Th17, so getting and a lot of signaling are being consequently appeared. So there is a strong evidence of an initial pro-apoptotic activity, but later on, in the majority of the cases, a prolonged wide effect on the bone marrow and to the immunological aspect of control of leukemia.
So I take this message focusing on the extraclonal story together with the clonal story.
Yes, and this could be probably not only related to pH-positive leukemia, but could be related to other disease and probably also solid tumor. Thanks for the question. Okay.
To
Thanks
Professor.
a lot.
We introduce now the part of the session in which we focus on elderly patients. And I introduce Tapan Kadia, great expert of AML in MD Anderson Cancer Center, to focus how they are integrating all these novel agents we have seen just now in their clinical practice of every day. Thank you, Tapan, for your...
Good morning. Thank you, Claudio. Thank you, Professor Martinelli, for inviting me to this wonderful conference, and I hope to see many more of these happening in the near future. So my job today is to talk to you about how we treat older patients with acute myeloid leukemia at MD Anderson. We know that it is two things that I want to focus on today is that, number one, older patients with AML is a very heterogeneous group, as you can see from this short case presentation of different patients. And the second thing is that older patients with acute myeloid leukemia, which represent the majority of patients that we see in our clinic, given that the median age of AML is about 68 years, is a distinct population that's different. It's not just patients with AML who are older, but that they have a distinctly different disease biologically, which you'll see by cytogenetics and molecular studies, by the fact that many of them have secondary AML, by the fact that many of them have been previously treated for their MDS with hypomethylating agents and then develop acute myeloid leukemia. So it is a very difficult patient population that we treat and a very heterogeneous one. So the way we approach acute myeloid leukemia in older patients with AML is to look into this heterogeneity, whether it be an older patient with many comorbidities who has some MDS-related changes, ranging to those older patients, those rare older patients who have core binding factor acute myeloid leukemia, which may still be curable with intensive chemotherapy, or patients who have FLT3 mutations or other mutations which can now be targeted with near-targeted agents. And so, as I mentioned, older patients have a distinct disease and a distinct profile that we need to attack. And there are two basic challenges that we face. Number one, older patients are by definition older. They have older organs, less organ reserve, and therefore it is difficult to deliver the intensive chemotherapy that we normally give to our younger patient population. They have multiple other comorbidities that may have developed over time, cardiac disease, renal disease, liver disease, which presents a unique challenge when we're trying to deliver intensive chemotherapy and even some of the targeted agents that we're delivering. Second, older patients tend to have more frequently a very poor prognosis disease, the ugly, as Dr. Martinelli presented just a few minutes ago, where they have complex karyotype, P53, secondary myeloid mutations, and adverse mutations. And so many studies, including our own, have shown that intensive chemotherapy may not benefit patients, older patients with acute myeloid leukemia, and we are now starting to switch to more lower intensity, less intense therapies, and now with the advent of next generation sequencing, targeted agents that can actually target specific mutations that can be efficacious but still have low intensity. And so how do we divide our patients, how do we identify this heterogeneity in our patient population? Well, we have for years used cytogenetics, we've used flow cytometry, we've used FISH to determine whether patients have favorable or adverse prognostic characteristics. Now, with the advent of next generation sequencing and some of the new technologies that are available to all of us now, or many of us, it is easier and easier to identify somatic mutations, recurrent somatic mutations, that not only help us determine prognosis in AML, but also help uncover targets in acute myeloid leukemia, for which there are now drugs that develop that you just heard from several of our distinguished speakers. And so at MD Anderson, with the work and help of our hematopathologists, we've developed several systems to try to quickly obtain these results. So new patients with acute myeloid leukemia come into the hospital, they need to be treated urgently. So how can we quickly identify that, number one, they have AML? What type of AML do they have? What are their cytogenetics? And what are their molecular studies? We have a quick hotspot mutation screen summary of the initial actionable mutations, things like IDH1, IDH2, FLT3, NPM1, that we can get within 24 to 48 hours on our patients so that we can initially start screening for the clinical trials, the appropriate therapies that would be appropriate individually for that particular patient population. Eventually, in the next 3 to 5 days, we get our larger gene back, right? We have an 81 gene next generation sequencing panel that was made possible by the hard work of our hematopathologists, and we're able to get this usually within 3 to 5 days. This adds an additional layer. What is the prognosis? Am I going to sit down with this patient and say, maybe you'd be a candidate for a reduced intensity conditioning transplant, or are you someone who is not going to need a transplant and may do well with just targeted therapy or low intensity therapy? And finally, a translocation panel, so that we can quickly recognize things like inversion 16, 821 translocation, Philadelphia chromosome very quickly before the full cytogenetic analysis comes back, because it's key to identify this early on before we actually go into the treatment. So, I just told you that our approach is mostly lower intensity therapy combined with targeted agents in older patients with acute myeloid leukemia. But is there a role for intensive chemotherapy in AML? So we've looked at this. Our frontline leukemia regimen, induction regimen, is CLIA, which is cladribine, cytarabine, and idarubicin, based on the Polish data showing significant synergy. And so the majority of our patients get CLIA in the front line. We do have a subset of patients, age 60 to 65, who have received CLIA, and this is how we've done, with a median survival about 10 months. But as you can see here, there's a plateau of around 30 to 40% out to 2 years, where some people are being cured. These are the older patients, so-called 60 to 65, who we deem fit for chemotherapy, who may be eligible for intensive chemotherapy and allogeneic stem cell transplant. But again, a small subset of patients and a median survival of 10 months. So there is a small population of patients. I think the more important population are those older patients who have core binding factor AML with inversion 16 or 821 translocation. Our appropriate regimen these days is FLAG plus gemtuzumab, azogomycin, or Mylotarg. This is what we use in our younger patients, and we dose modify appropriately, as you can see from this table, for older patients between the ages of 65 and 70, and even those above 70 years of age. And those who are truly unfit, we markedly reduce the dose and sometimes add hypomethylating agent in combination with mylotarg or gemtuzumab gazogamycin in that patient population. So a small subset, but there are subsets of patients who are older who may benefit from intensive chemotherapy. The vast majority of patients we consider older and unfit and move with lower intensity therapy. So for years, we were frustrated with the low response rates and unsatisfied with the long-term survival that we were achieving with hypomethylating agents as a single agent, either decitabine or Vidasa, with response rates in the range of 18 to 20%, and a median overall survival of about 8 months in the best studies. And so we've developed a regimen that we've used for many years, combining cladribine with low-dose cytarabine, a low-intensity regimen that can be mostly given as an outpatient after the initial induction, that is well-tolerated, and I'll show you, with low early mortality and high response rates. These are the doses and schedules. We give 2 cycles of cladribine low-dose Ara-C, alternate with 2 cycles of decitabine, back to 2 cycles of cladribine low-dose Ara-C, on and off, back and forth for a total of up to 18 cycles. We recently published our data, and I'll show you some of the results here. So this is historically important because this shows you what we are doing now with newly diagnosed older patients with acute myeloid leukemia. So you can see the median age of patients was 69 years of age, with almost half of these patients over the age of 70. And what we found here is a complete remission rate of 58%. That's a CR with complete count recovery in an older patient population of 58%, compared to roughly 8 to 10% CR rate with single-agent HMA. So a significant improvement in complete remission rate. And you can see the early mortality at 4 weeks, just 1%. So a safe, easily accessible regimen in older patient population that led to significantly improved complete remission rates. And you can see here the overall survival, median overall survival, 13.8 months, with a mature follow-up of 36 months. So 3-year median follow-up, median overall survival, 13.8 months, with cladribine low-dose Ara-C. And if you look in the diploid patient population, we could see a median overall survival up to 20 months in this patient population. Then came the revolution, right? Then came the discovery of venetoclax as a single agent in acute myeloid leukemia and in combination with hypomethylating agents. This is a summary of the trials that have been done so far, and Dr. DiNardo and Dr. Konopleva will go into more depth, so I'm going to kind of just go over this briefly. But again, a complete remission rate, which we had not previously seen with HMA-based therapy, of 70 to 74% in the front line, and a median overall survival of 17.5 months in the most recent update published by Dr. DiNardo, with a median CR duration of 11.3 months. So an outstanding improvement in overall survival and response rates with the addition of venetoclax to a previously mediocre therapy in hypomethylating agents. So our question became, if we are able to do so well with cladribine low-dose Ara-C and venetoclax can augment the activity of hypomethylating agents, can we similarly add venetoclax to cladribine low-dose Ara-C? And so our current regimen, which is shown here, is very similar to what we had been doing for the past several years, where we're adding venetoclax to cladribine low-dose Ara-C in our older patient population. The doses and schedules are listed there. We modify for the use of antifungals due to the CYP3A inhibitory activity. And we give 21 days of venetoclax during induction and anywhere from 7 to 14 days of venetoclax during the consolidation or maintenance phase of the study. We submitted this to ASH. You'll see some results at the ASH meeting, but I can tell you that the response rates are in the north of 90% in this newly diagnosed older patient population. Similarly, building on their work with HMA, which is Vidasa for 7 days or decitabine for 5 days in combination with venetoclax, Dr. Konopleva and Dr. DiNardo have then embarked on a new regimen of a longer duration of decitabine, the 10-day decitabine course given at 20 milligrams per meter squared daily for 10 days, combined with venetoclax. And you can see the recent results, outstanding overall response rates of 94%, also active in the FLT3 population when adding a FLT3 inhibitor to this patient population. So a significant improvement in what we used to see with HMAs, and these have become our standard of care for older patients with newly diagnosed AML. And this is the overall survival, median overall survival not reached, and a 1-year survival of almost 80% in this population. So now I said why we individualize and divide patients based on mutations. What do we do with FLT3 mutated patients with newly diagnosed AML? Based on the work done by Dr. Ravandi using Vidasa plus sorafenib in older patients with FLT3 mutated AML, we also have developed the use of quizartinib, an inhibitor you just heard about from Dr. Martinelli, in combination with azacitidine or low-dose cytarabine in newly diagnosed patients with acute myeloid leukemia. Preliminary results in the untreated population showed response rates as high as 89 to 100%, with a median survival of 21 months. Based on this, Dr. Davar and others in our group have combined venetoclax to that backbone regimen, where we use decitabine plus venetoclax plus quizartinib in newly diagnosed patients with FLT3 mutated acute myeloid leukemia. Since this is mostly active only in FLT3 ITD, we also use the combination of gilteritinib with HMAs in our frontline patient population. And those with IDH mutated AML, similarly, we are using IDH inhibitors. As you know, ivosidenib, the IDH1 inhibitor, is now approved in the frontline in the US as a single agent with single agent response rates in the range of 38 to 40%. Combining with HMAs, Dr. Donato has shown that the response rates are now in the 70 to 80% range in combination with HMAs with prolonged median durations of survival and response. And again, we're continuing with these in our patients with IDH mutated acute myeloid leukemia, hoping to see extra benefit and improved outcomes in this subset of patients defined by a mutation. Dr. Davar previously alluded to using a total oral regimen in acute myeloid leukemia, and indeed, in those older patients above 80 or those who are unfit or unwilling to receive chemotherapy, we are now considering the combination of IDH inhibitors in combination with venetoclax, just 2 oral agents for patients with newly diagnosed acute myeloid leukemia. Again, a limited subset, but again, encouraging results which we're taking forward in this new era of treating patients with targeted therapy. P53 mutated AML, one that we know is very adverse. Patients tend to have a very adverse prognosis, not only in younger patients, but particularly in older patients with acute myeloid leukemia, where P53 mutations are relatively common. We can see here a median survival of 6.6 months, low intensity therapy with prolonged schedules of decitabine or cladribine low-dose Ara-C seem to improve outcomes in this difficult population of patients. And so we have taken this approach where we use a prolonged schedule of decitabine in combination with venetoclax or other drugs to improve outcomes in this particular patient population. You heard about APR-246, which is a drug that may be particularly important in patients with P53 mutated AML via a novel mechanism of action. And so our approach, based on the study here with APR plus azacitidine, is to combine APR plus azacitidine plus venetoclax in newly diagnosed patients with P53 mutated AML. The last subset I'm going to discuss is the one I think is the most common and the most difficult that we treat, and sort of call those patients with secondary acute myeloid leukemia. These are patients that are defined by the WHO as those arising from a prior myelodysplastic syndrome, those who have MDS-related karyotype, or those who have AML with dysplastic changes in the bone marrow. And we recently found that, again, these are not all created equal, where those with cytogenetic abnormalities are potentially the worst, where those with just dyspoetic changes and no other diagnosis of MDS may not be so bad. But there is a particular subset of patients within this secondary AML, which I want to highlight, which are the treated secondary AML, a patient population that we are seeing more and more in our clinic because of the recognition of MDS earlier and the appropriate treatment with hypomethylating agents. And those are patients with MDS who have been treated with HMAs and then progressed to acute myeloid leukemia, what we call treated secondary AML, where we found a particularly dismal prognosis. So overall, these patients have a low rate of remission and a short CR duration and a short overall survival. We looked at our own data with looking at different types of agents, whether it be high-dose cytarabine, HMAs, CPX351, low-dose Ara-C, what works in this patient population. And you can see across the board that the response rates are stuck at about 38 to 40%. But importantly, you see that the early mortality, the 8-week mortality, is in the range of 20 to 23% with some of those high-intensity regimens, not only because they die of toxicity, but these people are not achieving remission. And so many of them are dying with active disease at 4 weeks, at 8 weeks, because of the lack of efficacy in this patient population. Median overall survival anywhere from 5 to 6 months. Nothing really works too well. And if you take this patient population and further subdivide it into patients in the red curve who have not received prior HMA and patients in the blue curve on the left who have received HMA, you can see that the median overall survival is extremely poor at 4.7 months. And so we are looking at new agents in this particular subset to see if we can improve outcomes. So how do we treat patients with secondary AML? There was a phase 1 trial of a drug called pevonedistat, which is a netylation inhibitor combined with 5-azacitidine, which showed particular promise in this subset of secondary acute myeloid leukemia. This was a paper published by Ronan Swords in a phase 1 trial. And if you look in the table on the right, those people with P53 mutations, a small subset, but 4 out of those 5 patients achieved a response with AZA plus pevonedistat. So based on our strategy of incorporating venetoclax, we're taking the next step, and Nick Short in our group is now combining azacitidine plus pevonedistat plus venetoclax in this difficult patient population of secondary AML and those patients with with p53 mutations. And so this is our approach to how we deal with this difficult patient population, in addition to several other clinical trials looking at this carefully. And finally, a word on CPX-351. It did show activity and improved overall survival benefit in newly diagnosed older patients with secondary AML. We're combining it now with venetoclax in this particular patient population, initially in the relapse setting, and then looking at it in the front line with secondary acute myeloid leukemia. So I'll end here, and I'll be happy to talk further tomorrow in detail during the morning breakfast session. But summarizing our approach to AML in older patients is to identify those people who will benefit from intensive chemotherapy and then quickly subdivide them by molecular genotype to targeted therapies which are appropriate for that individual patient. We're using new targeted agents, including antibodies. I didn't have time today to talk about transplant, but you'll hear about that in a few minutes. And maintenance therapy was also covered. So thank you, and I appreciate your attention.
Tapan, thank you for a fantastic presentation. What do you think about the new standard of care in frontline approach in elderly and unfit patients?
Yeah, so I think we've shown in many different studies and our own experience that I think the incorporation of venetoclax with lower intensity therapy has now become the new frontline standard for acute myeloid leukemia in older patients. HMA-VEN has been proven over and over again. The new schedules by Dr. Konopleva and Donardo using a longer duration of decitabine has outstanding response rates and excellent overall survival benefit. Our own initial data with cladribine loticercy, both as the doublet but also with the triplet of venetoclax, also is showing extreme promise. So I think for sure HMA-VEN has become the new standard of care there, and they were building to try to improve even on that. Other questions? All right, thank you.
Okay, thank you, Tapan. Now I introduce Alessandro Isidori, which aims to focus about the elderly approach in AML, but in Europe and in particular in Italy. Thank you, Alessandro.
Thank you, Claudio. Thank you, Giovanni, for inviting me here. I know that there are a lot of young people, so we saw a lot of dreams related to Italy up to now. So I just want to now ask you to put your feet in the ground, because my presentation would be probably an old-fashioned presentation, but it is what we have here. So I'm talking about elderly, so an old-fashioned presentation for the elderly population. Probably you won't mind about it. So AML increases with age, and thus the elderly population is the main target of our therapy. Unfortunately, as Professor Kantarjian showed before, there was an increase in the overall survival in the younger population that did not translate in an increase in overall survival, at least with standard drug, in the elderly population. Why? Because elderly AML characteristics are different from the younger population. There are less frequent good risk AML features and very low incidence of core binding factors AML. There are more frequent adverse risk AML features, secondary and therapy-related AML, unfavorable cytogenetics, including complex karyotype and monosomal karyotype, and higher incidence of unfavorable genetic mutation. Moreover, the health status of the elder patient is associated with several comorbidities, and these patients are taking chronic medication. And when we think about new drugs and the possible interaction between the drug that the patient is receiving and the new drugs that we are going to administer is something that we have to take in account. Moreover, together with Antonio Curti in Bologna, we put down in a paper the characteristic of the senescence of the immune system. As time goes by, the immune system gets more and more impaired, and thus we have to think also about the impaired function of lymphocytes, impaired function of NK cells, and impaired function also of neutrophils and antigen-presenting cells. Which are the standard options up to now? Intensive chemotherapy, that is only for a few patients, as I will show you. Most of the AML centers still perform 7+3. Most of these centers use daunorubicin, either if, especially in France, there is a large experience with idarubicin plus cytarabine, with or without a third agent. Low intensity chemotherapy, clinical trials with new agents. All the trials that you saw up to now are probably the best option for our patients here in Italy, or supportive care. What is relevant is to assess the fitness in order to make treatment decisions, because it's very important, as I will show you in a while, to be able to discriminate between fit, vulnerable, and frail older adults, because the population is diverse, and basically some patients might have a poor performance status and are thus undertreated, and others are an excellent performance status, but they may experience high toxicity while they get the treatment. So we need a comprehensive and objective method, probably more than one, in able to differentiate this kind of patients. And in Italy, the Italian societies, CSCS and GITMO, elaborate a few years ago a treatment algorithm in order to be able to make the best decision for this kind of paper. Feliceto Ferrara was the first author of this paper, and basically the consensus established criteria for patients to be treated or not. And I won't go into details, but those are the conceptual criteria and the operational criteria to define a patient unfit for intensive chemotherapy. And the major advancement was that they were able to define also patients unfit for non-intensive chemotherapy, namely low-intensity therapy. I know that with venetoclax and other drugs this might change, but by now, with what we have right now, I think that this can be a very important paper, especially for the younger people that are approaching AML, in order to be able to know which patients might be treated also with a low-intensity treatment. So in Italy, the choice is between intensive chemotherapy and HMAs or low-dose cytarabine. I show you the results of the largest trial performed with intensive chemotherapy, low-dose cytarabine or hypomethylating agents. The difference are huge. I would stress that the alpha trial that was presented by Claude Gardin at the ASH in 2017 used idarubicin and cytarabine and produced results that are not the standard in this patient population. So the patient was highly selected, and the objective of the study was to be able to bring as much patient as possible to reduce intensity stem cell transplant. So don't take these results as the standard for the patient population of the elderly, but as you see, probably in some centers that, as Professor Kantarjian told before, have a great experience in AML, also with intensive chemotherapy, you can have nice results. However, the fact is that the results are better also because it's difficult to compare hypomethylating agents with intensive chemotherapy. In another French study, they show that only few pairs were exactly comparable of patients receiving either azacitidine or intensive chemotherapy, and when you're able to compare this patient population, results are the same. So probably when you have higher results with intensive chemotherapy is because these kind of patients may not really be treated with azacitidine. When you exactly match these patients, you see that the results are the same. And a few years ago, we put down some criteria and some interesting points together with a group of Professor Venditti and Amadori, mainly to determine why we should choose an hypomethylating agent instead of intensive chemotherapy. And I will show you some points in a while. The first point is the improved tolerability with respect to intensive chemotherapy for hypomethylating agents, the activity in WHO MRC AML, the activity in patients with unfavorable cytogenetics or molecular alterations, and the presence of clinically meaningful response, even in the absence of a complete response. That is something that is really tricky for physicians that
used to cure AML patients. So regarding improved tolerability, in the AML-001 trial, it was observed the reduced relative risk of days in hospital for treatment-emergent adverse events, as you can see in the right part of my slides, for patients treated with azacitidine with respect to patients treated with intensive chemotherapy. Regarding the activity in WHO MRC AML, a subgroup analysis of the AML-001 trial was able to show a significant advancement in terms of survival for patients treated with azacitidine in respect to conventional care regimen. If you think about the curves that were presented by Naval, by Dr. Kadia, and all the other scientists from the MD Anderson, I understand that those are extremely unsatisfactory, but this is what we have right now as weapons able to cure this kind of patients. So I think that, again, these results might be kept in mind. Moreover, there is demonstrated activity in patients with unfavorable cytogenetics and molecular alteration for both azacitidine and acitidine in patients with monosomal karyotype, for patients with unfavorable cytogenetics, in which azacitidine was able to double the overall survival with respect to conventional care regimens, and for patients with molecular alteration. Here you see the results for patients with TP53 mutation, 7.2 months for patients treated with azacitidine with respect to 2.4 months for patients treated with CCR. And moreover, the cytabine administered in the more intensive way of 10 days was able to induce 100% of complete remission in patients with TP53 mutation. So very active in this setting of patients. And last but not least, the ability of giving a clinically meaningful response, even in the absence of a complete response, in a sub-analysis of the AML-001, again, you see that the results for patients that obtain such a response without having a complete response looks better with respect to the patients treated with conventional care regimen. Another point that I want to tell you is that this is also true for the cytabine, but for the cytidine, we also have the proof of principle that the data coming from clinical trial are reproducible in real life. So this means that we have not selected the patient of people that do not live in Earth, as sometimes it may happen with clinical trials. The people that were treated in clinical trials are the same that we treat every day in our clinical practice. And it's very important to keep in mind this point, because this drug is active in everyday clinical practice. Moreover, a sub-analysis of the E-ALMA series in 72 patients put down some criteria to define the patients that are more prone to obtain a response if treated with azacitidine, and you see here all the categories, and I would recommend to consider these criteria before starting a treatment with azacitidine. So, if we only have hypomethylating agents and intensive chemotherapy, we can conclude that survival is not worse with hypomethylating agents with respect to intensive chemo, that clinical benefit is seen also in patients who do not obtain a complete response, and the safety profile is surely better. But of course, we cannot cure this kind of patients with hypomethylating agents. So, can we do better? Probably yes, by optimizing intensive chemotherapy in a small number of patients, by using different strategies, and by surely combining novel agents, hopefully also outside from clinical trials. Regarding different strategies, again, I share with Antonio the interest of studying the mechanism of immune escape in AML. We have to remember that it's not only a clonal disease, but there is there are other points related to the microenvironment, as probably Professor Konopleva will tell, and other points related to the impaired immune system. relating to this cartoon, we have to keep in mind that in AML patients you have a blocked NK function, you have aberrant co-stimulatory expression, you have reduced T cell function, and you also have an immunosuppressive milieu that act in an immunosuppressive way and probably is responsible also for a lot of mechanism of resistance. So I will not give any details of these strategies, and probably those are not, the elderly population is not eligible for most of this trial, but I think that also Naval told us before that most of these novel agents and that are able to modulate the immune response or to improve the immune response might be introduced in the standard of care. Finally, I think that the new agents are clearly the answer for this patient population. I will not give you any details, but I just want to underline that Glasdegib is working on leukemia stem cells, so probably this is one of the new frontiers that is one of the facts why also venetoclax is working, because as we will hear later, the energy metabolism of the cells and the ability of targeting leukemia stem cells is probably one of the best mechanisms of this drug. And again, targeting the metabolic pathway of the cells, that is something that happens with anti-IDH therapy, is another very important mechanism of trying to improve the overall survival in the elderly. So finally, I think that we will probably see a resurgence of non-targeted therapy. Is not all related to FLT3. We have some non-targeted, more generalized agents that do not target a specific mutation, but that can be very helpful and active as a backbone therapy to be used in combination also with other drugs. So in conclusion, in Italy, low-intensity treatment still remains the default therapy for this patient population. There is no strong comparison data available between low-intensity and high-intensity treatment, also because the first bias is the choice of the investigator that choose one of the two treatments, because the other one is not it's not administrable to the patient. High-risk patients still benefit from hypomethylating agents, and the new drugs are coming and faster every day. So is it time for a revolution? I think so, and I thank you for your attention.
Thank you, Alessandro. As Giovanni Martinelli said, we have many limitations in Europe, and in particular in Italy. And I was thinking that maybe in elderly AML patients we have mostly limitation. I was seeing that recommendations are of 2013, so maybe at first we should focus about new molecular alteration, new cytogenetic alteration, and to integrate novel drugs also for elderly patients. What do you think? When we'll be able to add at least venetoclax maybe in routine clinical practice? Because we have many clinical trials also for elderly, but in real life experience, little institutions, what can do today to get more from elderly patients?
I agree with you, but it's a question that we have to ask to the Italian regulatory agency, because it's not up to us. I mean, until we do not have a recommendation from the Italian agency of drugs, we cannot just say, let's move drugs coming from clinical trials in the clinical practice. Regarding the little centers, I think, but it's my personal opinion, that Professor Kantarjan said a very important point earlier on. It's very specialized treatment, the treatment of AML patients, so we should probably still keep going with our working group, do things together, and be able to standardize the treatment as much as we can. Yeah, the recommendations are from 2013, but unluckily FDA approved 7 drugs in 2 years, and IFA neither one, so that's the reality.
I agree, totally.
So let me make a comment on how we choose patients for low-intensity therapy. So in my opinion, it's not a matter of age. If you have a patient where the 8-week mortality with intensive chemotherapy is more than 20%, this is when we give them low-intensity therapy. And at MD Anderson, we developed a model based on 1,500 patients where we showed age over 75, complex karyotype, performance 2 to 4, AHD and creatinine more than 1.3. These are the adverse factors. So we try to propagate them in the United States, and then people started using the transplant criteria, and then suddenly came the Ferrara criteria, which are not based on any data. They are a consensus opinion. But suddenly the FDA became in love with Ferrara criteria. So now all the studies in elderly are forced to use the Ferrara criteria, which take patients almost on their deathbed. So if you use the Ferrara criteria to select patients for low intensity, any study with even the best agents will be negative. So I wish the Italian group would go back to your experience in 10,000 patients and develop objective criteria for an 8-week mortality, which are different from the Ferrara criteria, which are criteria for deathbed. I mean, you can't do any studies with the Ferrara criteria. Your opinion?
Oh, you know, I'm a friend of Feliceto Ferrara, so I can't say anything, but, you know, I will never say something different from what you said, so that's my comment. Thank you. No, I agree. I mean, we should put our data together and try to see if there are objective criteria. I agree.
I have a question. Don't you think that the clinical application of allogeneic stem cell transplantation in elderly patients up to the age of 70, 75, which has become daily practice in academic centers, might change the approach to the induction and consolidation therapy to bring more patients in complete remission to allogeneic transplantation?
Yeah, that's
not just addressing the survival.
No, that's a very good point, but if we think about that, and this was a question that I want to ask to Professor Kantarjan, if we see at the CR data and the toxicity data, we should take the venetoclax plus hypomethylating agents and bring these in frontline therapy also for the younger population. So,
we were very skeptical about transplant up to the age of, let's say, 78 and so on. But now I'm not sure if Dr. Konopleva and Kadia will show the data, but in both the low-intensity therapies, the cladribine, Aracif, venetoclax, and then DAC 10 days venetoclax, when we get the patients to a transplant and accounting for all the bias in the timeline and so on, a patient who gets transplant does better than a patient who doesn't get transplant. And this is for people age 60 to up to 78. So we're pushing more towards this approach, low-intensity therapy to get them better, get them in a marrow complete remission, and then if there is the potential for a transplant, then transplant, and perhaps a post-transplant maintenance.
thank you.
Starting from the discussion about allogenic transplant, we close this session with a question which we give to Professor Rambaldi about what is the role of allogenic transplant in AML in target therapy era. Thank you, Professor.
Thank you for the kind invitation. And I'd just like to start underline the fact that for the time being, allogeneic stem cell transplantation still remains the most effective post-consolidation treatment in AML. And I'd like to underline my personal opinion, based on our data, that perhaps not all the treatments are equal in AML. And this is our experience on the attempt to induce a higher and deeper proportion of CR rate early during the treatment of AML. And these are the results that we have published. Of course, it's the results of one trial. Maybe that is not confirmed in some but not all the other trials, but apparently getting an early and deeper remission do translate into a better overall survival. And the merit in our experience of this was by far related to the higher proportion of patients who achieved the chance to be allogeneic transplanted. So the results of transplant is getting better during the past 20 years, and these are the results of our randomized clinical trials comparing two myeloablative, but with different toxicity conditioning regimen that allows to reduce the non-relapse mortality in a significant manner when fludarabine instead of cyclophosphamide was combined to a myeloablative dose of busulfan. So, and this trial was performed in a patient population with a median age of 51 and up to the age of 65. And this, globally in the world, particularly in the United States, has translated into a higher proportion of patients with AML who are nowadays transplanted, and this is steadily going up. And this is also related to the fact that not only we have better remission, but we have a plethora of available donors that allows us to offer the allogeneic transplant to more than 90% of patients, thanks to the introduction of the haploidentical donor and the cord blood transplants. But still we must improve, and this is the reason why we must implement in the daily clinical practice of a deep molecular analysis, particularly in patients with a so-called normal karyotype. And these are the results that we have generated in the context of the previous clinical trial that simply tell us that very basic point is to start to discriminate in the group of normal karyotype AML, those bearing or not the FLT3 ITD mutation, because their identification translate into a very important clinical difference. And for those who are NPM1 negative, the addition of any one of the NMT3A, FLT3 ITD, RANKS1, the IDH1, and U2AF1 translate into a worse clinical outcome. So what can we do with this information? This is the impact of the minimal residual disease in patients who had an NPM1 positive AML. Now, it's clear that those who achieve a deep molecular remission do better, no matter if they get a transplant or not. But for those who do not achieve a deep molecular remission, the impact of allogeneic stem cell transplant is at least limited. We can say that. And so this is something in which we must improve. So, as it has been already mentioned early this morning by Professor Kantarjian, allogeneic stem cell transplantation is not anymore the final act in the treatment strategy. It's rather a platform on which we can build up a better treatment. And the use of post-transplant treatment is of paramount importance. This is an important trial that has been presented last ASH meeting, and with the use of an off-label drug, by the way. And sorafenib added to a patient bearing the FLT3 ITD mutation after transplantation probably is associated with a significant improvement of the outcome. The trial was not properly designed for allowing us the final statement, but is a remarkable indication. This is another important trial, which, by the way, is ongoing in our center and in some other center in Italy, which, believe it or not, recruits patients with great difficulties. And this could be a missing opportunity for our community. And I urgently recommend the colleagues to enroll patients into this randomized trial testing the ability of gilteritinib, which is very well tolerated even for allogeneic transplanted patients, to demonstrate the benefit of such a post-transplant strategies. Now, do we have alternative strategies to chemotherapy? Yes, we do hope so, and it has been alluded to the future possibility of two hypomethylating agents alone or in combination with biological drugs. We all are aware of the outstanding results that Dr. Denaro has recently published, underline the concept that if you wish to bring a patient to transplantation, you first have to achieve a complete hematological remission. And probably this is an opportunity for the future. Now, let me conclude my presentation saying a few words on secondary AML. This has been already touched by the previous speaker. I'd just like to emphasize the point that clinically, you usually define in adult patients a secondary AML patient in no more than 25% of the patient population that you are exposed to. But if you go deeper into the understanding of the biology of the disease, you realize that the molecular profiling of so-called de novo AML is most likely associated to a secondary disease. And so we did that, and we changed the estimate in the daily clinical practice of identifying secondary AML from 19% to 42% in a median age of population of 52 years. So NGS is also important to identify this signature. And perhaps that we do have not a biological drug, we have an innovative formulation of all drugs, that is CPX, that we hope that can increase the proportion of patients that achieve a remission, and has been already said, that can achieve the chance to be allogeneic transplanted. This is an important opportunity to be confirmed for the future. So allogeneic stem cell transplant has dramatically improved the outcome of AML patients by reducing the transplant mortality and toxicity, because we are able to find a donor for each patient who is in need of a transplant, and because we have been able to increase the rate of CR before transplantation. MRD detection is important, but not enough to improve further the results. Thank you very much for your attention.
Thank you, Professor Rambaldi. About previous discussions, what do you think is near future for maintenance post-allogenic transplant in Italy?
In Italy, we must adhere to good clinical trials. We have one ongoing, and for unknown reasons, the recruitment to such a good trial is very delayed. And I think that there's been a recent editorial in Journal Clinical Oncology underlined the absolute need to perform good quality clinical trials to move the knowledge ahead in this context. And I think that we must do it.
We were intrigued by the data you showed initially with the SHD versus ICE.
Yes.
What were those two regimens specifically, and how do you interpret that data in the general practice?
Okay, we have been using ICE as the standard induction chemotherapy. Is a 3 drugs based regimen based on idarubicin instead of daunorubicin, 12 milligram per square meter. And the challenger was a high dose cytarabine in combination with idarubicin in a sequential, given in a sequential manner based on the previous German experience in AML, in relapsed AML. So it was the German arm. And by such an approach, the proportion of CR was improved. And apparently this translated into a better overall survival. But the important thing was the median age of the patient population that was recruited. And it was stated in the slide that the median age was 52. So
it's interesting, there are now accumulation of studies that use high-dose RRC induction that show a better outcome, and yet in the United States this has not been taken up. So there's the Dutch study that showed that among patients under the age of 45, high-dose RRC induction with high-dose RRC consolidation improves the outcome. There's this trial, which I wasn't aware of. There's the MRC trial with FLAG-IDA. So there is now accumulation of studies where high-dose RRC used in a classical fashion during induction and consolidation could show better results than a 3+7 followed by high-dose RRC.
But you know, published those data in 2018 was probably out of fashion, and so maybe that the referee was not complete in agreement with our hypothesis. But this is, our data are clean. And
so I had another question about the NPM1 positive and transplant. So you showed that those who became MRD negative, I'm assuming by NPM1 molecular.
Yeah, absolutely, molecular definition.
They did 81, 86% similar. But then you said those who were NPM1 positive MRD transplant, it looked like was not great, was better, 52 versus 31%. So you would still take them to transplant.
Yeah, absolutely. It was a small cohort of patients. I definitely believe that for the time being, any patient who is MRD, molecularly MRD positive, should be allocated to allogeneic transplant. But still, there is room to improve for those patients. And this is why a post-transplant strategy is more than welcome for all of them.
Professor Rambaldi, MRD is very important, but do you rely only in single point determination, or do you need a confirmation of a particular result or a negative result?
Thank you, Vittorio, for this question. The analysis was performed at the end of the chemotherapy consolidation. So after the conclusion of the high-dose cytarabine cycle 3 in the treatment program. This is roughly similar to what was published by Ivy in the New England Journal of Medicine as the key time point to take the clinical decision. But maybe this is not the most appropriate way to test it.
Okay, thank you.
Thank you.
This was really, thank you, Professor. This was really a wonderful session, and I think that everyone agreed that the best way to close it is to listen to closing remarks from Professor Kantarjian.
So I think it's a new era in AML therapy. All of us are very excited about not only optimizing the chemotherapy in AML, and I was very happy to see that additional study, if you can send me the reference, because it adds to the weight of evidence that there's something better than 3+7. But now we have multiple drugs that we could use to add to the benefit, including venetoclax, several targeted therapies, and now oral maintenance with an oral azacitidine-based therapy. So I think in the next 5 years, we'll see something very similar to what we're seeing in ALL, namely a big improvement in the outcome of the patients if we optimize the therapies. It reminds me very much of the Philadelphia positive ALL. That used to be the worst of the ALLs. Now it's the best of them. FLT3 positive AML is considered by many the worst, but we have data at our institution that if you give them FLT3 inhibitors with chemotherapy followed by transplant, followed by FLT3 therapy, actually they are starting to look like the better subtypes of acute myeloid leukemia. So thank you for attending this, and let's introduce the next session, which is a continuation of the concept, targeted therapies in AML, chaired by Drs. Martinelli and Mekuchi.